Welcome to this tutorial on evaluation and management modifiers presented by Provider Outreach and Education. The information given in this training is correct as of the date of publication. The most current information contained in this presentation can be found on the Noridian Medicare website and the CMS website at the links listed on this slide. Modifiers do just that. They modify the code when appended. A modifier is used in specific circumstances and improves the accuracy of the code. This tutorial will look at modifiers that may only be appended to evaluation and management codes. Modifiers are always 2 digits and may only include alpha characters, numeric characters, or a combination with 1 alpha and 1 numeric. For this tutorial, there are not any alphanumeric modifiers. There is a possibility that some evaluation and management, or E&M services, during a global period could be unbundled using numeric modifiers 24, 25, or 57, and 3 alpha modifiers provide additional information in certain circumstances. These modifiers are only used on evaluation and management codes. We will discuss the details on each modifier during this tutorial. Here is the basic information regarding global surgical days. Minor procedures may have a global period of 0 days or 10 days and does not include preoperative visits before the procedure. The visit made on the day of the procedure is generally not payable as it's included in the payment for the procedure, unless a significant separately identifiable service is also performed, in which case modifier 25 needs to be appended to the visit. The postoperative period of 10 days applies to some minor procedures. The 10 days are counted from the day after surgery. Separate payment for postoperative visits during the 10-day period would not be allowed. Major procedures will include 1 preoperative day before the surgery, day of surgery, and 90 days following. Any E&M service performed during the post-op time may need modifier 24 if separately identifiable. Global days for each procedure can be found on the Medicare fee schedule database. Our first modifier, 24, is to be used for an unrelated E&M service by the same physician or other qualified healthcare professional during the postoperative period. This modifier is used by the surgeon to indicate that an E&M service or eye exam, which falls within the global period of a major or minor surgery, is unrelated to the surgery recently performed. The diagnosis code is usually different from the surgery, and additional documentation must support the E&M service is unrelated. Here is an example of a patient that went in for an incision and drainage of a simple cyst on February 1, and this procedure has a 10-day global period. Then 6 days later, had an appointment for a cold. Since it is non-related, a modifier 24 needs to be added to that visit and both will pay. Without modifier 24, the February 7 visit will deny as billed during the global period, even though the diagnosis might be different. In this example, the doctor did a cataract surgery on February 15 on the patient's left eye. Then during the 90-day global period, he examined the right eye. Although the diagnosis is the same, it is the other eye, so a modifier 24 can be appended to the E&M visit, and we will allow this visit during the global period. The patient's documentation must show that it is the other eye that was examined during the global period. Is an E&M really needed when preparing for the other eye? Maybe this visit isn't even necessary if it was determined that they would operate on the left eye, and when that healed, do the same to the other eye. So if it was predetermined before the first operation, then no visit should be billed. Now here's a different example. The surgeon had to go in after doing a major surgery and incise over the infected area, isolate the vessel, and explore for postoperative complication, such as a hemorrhage, thrombosis, or infection. The surgical procedure is okay, but it needs a modifier 78, indicating that the patient had to return to the operating room because of complications. However, the E&M visit charge on that day should not be billed, even with a modifier 24, as it's bundled into the surgical procedure. Now following the same patient, after the exploration, 5 days later, the patient developed a urinary tract infection. Since this is a totally unrelated condition, the doctor can bill for the E&M visit and append a modifier 24. Moving on to modifier 25, this is only used on claims for E&M services or eye exam codes, and only when these services are provided by the same physician to the same patient on the same day as another procedure or other services. This modifier may be used to indicate that an E&M service or eye exam was performed on the same day as a minor surgery and is significant and separately identifiable from the usual work associated with the surgery. Documentation in the patient's medical record must support the use of this modifier. This modifier does not need to be used with E&M codes that are explicitly for new patient visits, as they are excluded from the global surgical package. However, a new patient visit on the same day as chemotherapy or non-chemotherapy infusions or injections does need the modifier 25, as those are not considered surgery. The National Correct Coding Initiative, or NCCI, manual provides coding language to use modifier 25 when providing a significant and separate E&M on the same day as an injection or infusion. A different diagnosis from the one submitted for the surgery is not required. What is considered significant and separately identifiable? This means the history, examination, and complexity of decision-making needs to be above and beyond information documented for the procedure. Here are some questions to consider. Does the complaint or problem stand alone as a billable service? Did the provider perform and document key components of the E&M service unrelated to the procedure? If the same diagnosis was extra work above and beyond usual pre-op and post-op work associated with the procedure? Minor surgical procedures, which are 0 or 10 days post-operative, or procedures with XXX indicators, includes a pre-procedure, intra, and post-procedure work in the procedure allowance. Unless the visit was significant and separately identifiable, it is included, and an E&M visit should not be billed separately, and this applies regardless of whether the patient is a new or established patient. Here is the definition of a new patient. A patient who has not received any professional service or a face-to-face service from the physician or physician group practice with the same specialty within the previous 3 years. For example, if a doctor did an EKG reading on a patient's EKG strip, then the patient was referred to him as a new patient, and he can bill this as a new patient visit because there was no face-to-face visit when he did the interpretation of the EKG. But if a patient was his patient at one clinic and he left that clinic and opened up his own solo practice, and this patient decided to follow him, this is not a new patient. These are all new patient codes that are excluded from the global package and do not need a modifier when billing to Medicare. Most of the descriptions for these codes specifically say new patient, but some codes, like the initial hospital visit codes, are for new or established, but those are not listed here as excluded. For emergency room visit codes, there is no distinction made between new or established patients, but those codes are listed. The reference for this slide is the Internet-only manual, publication 100-4, Chapter 12, Section 40.3, and is in the resource section for this tutorial. Here we have a list of E&M types of visits that are included in the global package, so be sure it's appropriate to bill. The full list of codes can be found in the CMS Publication 100-4, Chapter 12, referenced on the resource slide. In this first example for Modifier 25, after examining the patient and confirming for allergies and their immunization status, the doctor obtained consent from the patient and sutured the laceration due to head trauma. An E&M is not separately reported because there was no significant separately identifiable service rendered. Using the example in this scenario, the patient was dizzy and dazed or showed other signs that something else was wrong. The doctor decided to do a full medically necessary neurological exam to make sure nothing else was going on internally. In this case, an E&M visit may be separately billable. Remember, to bill for a visit, the history, exam, and medical decision-making must be performed. Our third example shows a physician seeing a brand new patient with no complaint. Since the patient is a new patient, an evaluation may be necessary to determine if there are any problems. After evaluation, the doctor is doing a full body exam with history and moderate decision-making and notices the patient's knee is tender and informed the patient that an arthrocentesis aspiration was necessary. In this case, since an E&M was necessary, an E&M code for new patient visit can be billed. Because it's a new patient visit, no modifier is needed and both charges will be paid. If the doctor decided the patient needed another joint injection a few days later, now this patient is an established patient, so even if the doctor feels that he needs to evaluate the condition again, this evaluation is bundled into the arthrocentesis aspiration procedure and no E&M visit can be charged. Here's another twist. Let's say Dr. A referred a patient to a proctologist for a screening colonoscopy. This is a new patient for this physician, so he wants to bill for an E&M visit and the colonoscopy. In this situation, if the doctor is going to do the colonoscopy on that day, then the E&M is bundled into the procedure. This would not be considered a significant separately identifiable service. The theory behind this is the patient has already been evaluated by Dr. A before he was sent for the procedure and the colonoscopy was requested. So that is all that needs to be done. Moving on to Modifier 57, E&M services on the day before a procedure, the day of the procedure, and within the 90-day postoperative period are generally not payable as it's usually part of the global package for a major procedure. However, Modifier 57 may be used to indicate that an E&M service performed on the same day or the day before a major surgery by a surgeon resulted in the decision to perform the procedure. There must be documentation in the patient's medical records to support the use of Modifier 57. This modifier does not need to be appended on visits made to decide whether surgery is necessary if it was made more than a day before surgery. For example, 1 week prior. If the decision to have surgery is done a week prior to the actual surgery, no modifier is needed, and any visit made on the day before or day of will be part of the surgery fee. If the decision to have surgery is done on the day of or day before, then a Modifier 57 needs to be appended to the E&M code. Modifier 57 cannot be used for minor procedures, and an E&M with Modifier 57 appended for a minor surgery will deny. The decision to perform a minor procedure is typically done immediately before the service and is considered a routine preoperative service. A visit or consultation is not billed in addition to the procedure. In this example, a surgeon was called in and admitted the patient to the hospital. At that time, the decision was made to have surgery the next day. The modifier 57 is appended to the 99221 visit. The surgeon was the admitting provider, and modifier AI is also appended to identify the principal physician of record. Now, if the decision to have surgery was made a week ago, then modifier 57 is not necessary. In this same situation, if the surgeon saw the patient again the day before the surgery, no charges can be billed because it's part of the global package. Here are the additional modifiers that could be appended to an E&M code. Medicare developed the AI modifier when it was determined it was necessary to identify the principal physician for the inpatient admission. Use of this modifier allows other specialist providers to submit claims in addition to the physician coordinating care for the patient's inpatient encounter. Modifier FS identifies a split or shared E&M visit. When a physician and a non-physician practitioner from the same group sees the patient on the same day, the billing provider performing the substantive portion of the visit appends modifier FS to the E&M visit. Split or shared visits are only performed in an institutional facility where Incident to guidelines are not allowed. Modifier FT identifies critical care services that are unrelated to the surgical procedure when performed during the global period. Append to the critical care E&M service only. Here are a few resources from CMS to review the coding policies and guidelines discussed during this tutorial. Thank you for taking the time to listen to our tutorial. Continue your learning experience by referring to additional recordings available on the Noridian website or YouTube channel.